right side of the manipulation. Okay, so I have less way of manipulation. That's why I'm keeping my endoscope a little bit inferior. So so here I carry on dissecting. And then if I have an elevator, a small elevator, flat one, a duckbill or type or any elevator. So I try to raise a very small flap. Okay, I have a huge elevator. So this is to show you with so for tympanotomy, if the purpose is just to check what is inside and maybe sometimes do a biopsy, or if my target is just this area where I'm going to show you, I will raise a small flap. Okay, so this is probably the smallest tympanotomy that you're going to raise to do any procedure. So I would use a suction. I need a smaller suction end. So with a microscope, you won't be able to see the structures, but I'm going to show you the structures that we can see with even a very small axis. So this is still a 0-degree lens. So you see the malleus and the incudus, the pedial joints, and also the promontory, most part of what is inside. Okay, it's also a very good way of starting your anterior tympanotomy. So now I use a round knife. I extend it to, say, a standard one, which we can do laryngoplasty. So if you have a perforation right over here, you want to repair, this is probably the smallest flap you can do for the repair, and then you can put it back. So I also use it as an analogy of our colleagues, ophthalmologists who are doing a cataract surgery. They raise a very small flap and they use it. Manipulate the corda without sort of injuring it. So now we move the endoscope. So we see the other side of the ventilation tube. Suction. Not working, not working. So I will take the grommet out and see how we can repair the perforation. So the materials that we are using, what do we have today? We have artificial material, biodesign, fascia, or whatever to show them. I take the grommet out so that we now get a perforation.有咩？可以啊。Okay, so I would do what we call a tragal perichondrial graft. So we show you how we take the tragal perichondrium. So there are many cartilages you can use around the ear canal. So why the tragal cartilage perichondrium and the composite tragal cartilage is the one that we like to use is because it's right at the ear canal. So if you make an incision inside, knife 冇 knife 都唔緊要，俾個 elevator 我都得，闊少少 sharp。So okay. The cartilage is surprisingly big, okay? So we could use any size. For this one, we can use a small graft, but I'm showing you how big a graft we can do and how big we can actually elevate. So this one, you do need to stitch it back afterwards. 3 years. So after cutting through the skin, you get to the cartilage. So you'll be able to see the cartilage. 帮我 hold 住佢。So this is the cartilage. And you can elevate it with your skin or elevator or pair of scissors. So I'm still using a single hand, but of course you can ask your assistant to hold the endoscope and you have your second hand in elevating it, which I will need Carrie to hold the endoscope for me so that I can use the second hand. Okay. So this is the cartilage. So I'm showing you if we want to harvest a cartilage, there are many ways of harvesting it. I'm showing you the easiest way. I'm not showing you a more difficult way. So I will make one cut through the cartilage first. Okay. So say if I want to take a little bit bigger, I raise the flap higher. Okay. Let me make the incision a little bit bigger. Show everybody. Okay, so I make one cut through the cartilage. So I get to the other side of the cartilage. So this is the other side of the cartilage. You can get closer. And okay, so I'm getting to the other side of the cartilage. Then you can harvest a big piece of cartilage. So I'm taking a good size first, and then I'll trim it and just take the perichondrium. Usually I will use a non-tooth forceps because a tooth one could be quite damaging to the cartilage itself. So quickly take one. So I handle it with care because it's a tooth. So I'm taking not a big piece, but just show you that this is the one I'm getting. So let me show you how we cut it for a composite, a very thin cartilage with perichondrium. So there are two sides of it. If you trim away some of the excess fat, so both sides can be used. And I will usually, for a small perforation, which is anterior, say for instance like this, I will use a very thin cartilage along with the perichondrium on the other side, but this is also a backup for this side, okay? So let me see whether I can do this by taking a small thin cartilage. You can use a cartilage trimmer, a commercially available one that will make sure that the thickness is uniform. In most places, we don't have the trimmer or the luxury of having somebody do it for you. So you just do it, and then you can revise the thickness if you like. Okay, so this is a fairly thick one. So suppose you have a good size one, you want to trim away the perichondrium. The better way to do it is to actually remove the cartilage rather than just taking the perichondrium. So it's easier for you to remove some of the cartilage and keep the perichondrium part on the side. So I will use this anterior part of the cartilage to cover the perforation for the tympanoplasty or standard cartilage tympanoplasty. So leave this wing over there. So in the operating room, of course, you can take your time. I have quite a lot of steps to show. That's why I'm doing a bit rush. Okay, so the perforation is a small one. So I think you just need the appropriate size. Okay, so let me quickly demonstrate and we follow on. So now we have the graft ready. We have the crocodile forceps. We have the flap elevated and elevator. Okay. So we want to repair the perforation over here. So we take the piece of graft. Okay, thank you. It's not a big piece, but a little bit of ragged edge. So this is a composite cartilage perichondrium. So you can put some gel foam in. We don't have gel foam, but we can crocodile. we can just make some paper, put it down in gel form. 止水 with elevator. Oh, thank you. I just put some paper in as if I'm putting some gel foam down under for the support, and we remove that. Okay. Okay, enough. Yeah. So so suppose these are gel foams, and you will put some gel foams inside with your single hand. Not easy. So paper is a lot difficult, more difficult than gel foam itself. So it's sticky. But so when you handle very sticky stuff, you do have to sometimes manipulate your instruments. So suppose this is a gel foam. Okay, so we'll recover the flap and check. So you can see that the perforation is covered right over there, and there we are having and the replacement of the flap on a tympanoplasty. So there's a bit of tear over here, it doesn't matter. Okay. So let me clean up and show you. So after completion, with the endoscope, it's very easy to check. And so this is an anterior perforation. We don't need any incision. And we check, and if there's a little bit of gap, you can always manipulate. I think there's a tiny gap anteriorly, so we'll check, and we put a little bit more gel foam support to the front so that this gap could be filled up right over here. Okay, so so suppose that we have finished this part out. Okay, so next thing is I always tell my resident that before they learn how to repair an eardrum, they have to learn how to tackle the ossicular chain, because this is something that you must do when you are doing someone for a functional ear surgery. They have a hearing loss, a conductive loss. You've got to check the ossicular chain and see what exactly is happening with the ossicles before you move on to do the myringoplasty itself, or to plan for the surgery to help the patient to restore hearing. So, so you need to understand and learn it, and it's pretty easy for you to see the ossicular chain, even without taking away any bone with the endoscope. Okay, so if I lift the corda away, you can see that I can see the entire malleus almost up to the neck and the process space. I can see the handle and the long process right over here, and the long process of incus and the head of the stapes without removing any bone. So if you have a curette, get me a curette. If you want to see a little bit more, so removing a small area of bone will help you to see a lot more. Okay, so do it a little bit rougher than before, usually. Just to quickly show, say 1 millimeter of bone get you a lot of feel. You could do that with the microscope, but the view that you're getting is obviously will not be as good.我睇唔到個鐘，你記唔咗 ？Suction。Okay, 快少少。Curate。If you use the microscope, you have to remove a lot more bone. So here I'm just removing a little bit of bone right over here. Needle. Now you get to visualize the stapes fully, the facial nerve. If you get close, you'll be able to see the processes, cochleariformis, the bulge right over there. So you can test the ossicular chain. You can see the area of the oval window. You can see the facial nerve, and which is right over there. We do have the bony canal on the facial nerve. And then a little bit of adhesions right over there. So in a standard surgery, this is your view. A little bit of bony exposure, you get a full view and a test of the entire ossicles. So we can do an ossiculoplasty right over there. Do we have a top or something like that? So suppose we have the incus missing over there. You could put a partial right over there fairly comfortably and a piece of cartilage on top. If you want to put a top in, you can put a top in comfortably with just this flap. So let me show you a partial first, okay? So I have some plastic dummy. So oh, sorry, this is a top, or this is a partial. So take this one out for me. So I don't damage the ossicular structure first. I will leave most of the middle ear anatomy and later going to the cochlea for Dr. Zhang Weiji to show you. Okay, so I'll finish with the ossicoplasty and then I will show you how we do a standard cortical mastoidectomy. So needle. So you can use a needle to dislocate the incudostapedial joints, which because I want to show you how we do a pop. So I dislocate a little bit more to get the top part of the. Okay, so I dislocate it purposefully so that we can put a partial prosthesis onto the stapes head. Okay, so now you get to see this beautifully. Then you can put your partial suction. Many ways of putting the partial in. So if you could actually flip it and so that the suction is sucked on the other way. Okay, so this is how you put it in. do it again. Release. We'll see whether I can manipulate this one. Because the incus is replacing back to the original position, so that's why I can't do it now. It's okay. No worry. I take it I will do it again. So harvesting things with one hand sometimes is difficult. So I won't do much. I will try it on the second go. So usually it's easier with the real one for release. So let me assume that I'm in the right place, and then I push. I put a piece of cartilage. I check. The corder is in my way. Okay, so now I'm in the correct way. The incus is pushing it a little bit further to the back. Then I put a piece of cartilage and I finish the surgery. Say, suppose I have a cartilage, then this is a big piece, but cartilage is to prevent extrusion. Then I cover with a flap. Okay, so it's a very big piece of cartilage, but it's okay. So now without delay, let's shift to the microscope and we'll do a cochlear implant on now. So let's shift to the microscope. So we have 1040, quite some time to show you, okay. So this is a post-auricular incision. So we make an incision on the sulcus. Incision can be big or small. The standard one starting from the rim, actually the edge of the concha all the way down, okay, where you cover the entire ear canal. So this is the canal. It has to be at least coverage of the ear canal. Of course, it depends also on the variations. And here we try to expose the mastoid tip as well. So, and we want to follow the line of the zygoma. Okay, so this is the root of the zygoma. You can feel it, actually. You can feel the root of zygoma. So definitely the root of zygoma show you where the middle fossa is. So we're well above for the middle fossa. And then you elevate the flap, you identify the landmarks. For a very beautiful, transparent, pneumatized mastoid, you can see the air cells, already see the air cells right over there. So we start with the drill. The drill is a power instrument. There are many drills available. So modern drills are usually electrical driven and they're high-speed drills. Which one? DNA, okay. So what do we have today? 80,000 RPM. So this is 80,000 RPM, high-speed drill. And you can see that it will shave along easily, bone away. So if you don't use 80,000, you can slow it down, which I will show you the difference between slowing it down and and then splitting up and the difference between the two. So you see the spine of Hanley over there where it points you to the antrum. The best way of doing a cortical to start to do it, of course, is to get to the air cell system. And my convention is I will go from superior to inferior. That will show you better the entrance to the master antrum. So also if you don't have an imaging, you probably won't know the position of the sigmoid sinus, whether it's a contracted mastoid or whether it's a pneumatized mastoid. So assume that this is a pneumatized mastoid. Let's start with, say, the usual cortical that we are doing. So I'm outlining the air cells that we're going to remove. So nothing in a rush. Is a pretty simple procedure. So if you look at it, I have a fairly big burr, and I use the side of the burr to focus on the bottom. Okay. We can zoom in a little bit more for zoom in. Too much. It's okay. The light feel 係個圈嚟嘅。Okay, so we have very good view now. So the microscope is different from the endoscope because, as I said, there's no distortion on the side. So if you work on the side, you're still at the same ratio as if you're working in the center. So it's a lot safer on that sense, okay? So once you encounter the air cell system, you will follow the cells, okay? So I use a very big burr and I use the side of the burr. This is a fairly high speed, so it's good for tough bones. So I follow the dura here. So let me do it. So I show you the tip, master tip. So this is a very pneumatized bone. So this is a very large SL. So I just make sure that I'm not entering into the sigmoid sinus. I'm actually using today the binocular as an exoscope to do the surgery. So we can discuss about the use of exoscope now, where most of the time I'm using a 3D exoscope now. But a microscope is still very useful for, say, when you need both hands, when you don't really need to use the endoscope a lot. So we follow the cells, and then we try to blue line the structures one by one and getting into the hair cells. So this is a 8mm. So I'm using still a very large burr for the purpose of doing the cortical. This is too large for most people in the beginning. Okay. So I get to a smaller burr to get through the air cell system. Okay. So this is a 5mm cutting burr. So I'm shaving the bone layer by layer with the smaller burr, but the purpose is I'm still looking at the margin and the limit. Superiorly, you're looking at the middle cranial fossa as your margin of dissection. Now you can see I'm blue lining the sinus. So without actually breaking through. All the bones. I like to shave the bone with my cutting. Use it like a diamond. So this technique can be practiced. So I follow the middle fossa dura. I'm shaving it. I'm not sort of breaking it through. So that you will be able to see the thin middle fossa with the bone still right over there. Okay. If I want to cut in advance, I will move it purposefully and cut in advance. So saya. Okay, so now I have a 4mm cutting, and then I get to follow the cells to find the mastoid antrum. Okay, so we're going through the ASL system. We have the middle cranial fossa dura along superiorly. We have the posterior canal wall. We're moving towards removing the zygomatic air cells along the line. So moving forward, these are all the zygomatic air cell system. Okay, so shift down a little bit the speed of the drill so that I get a lot more control. Okay, this is a very big burr for this purpose, but I'm okay with it. For most of you, you can start using, I need a smaller suction, start using a smaller burr. Once you get along, have a good feel, you can use the 4mm to get to do this step. Yeah. So you are慢啲. Oh, thank you. Okay, okay. So we begin to see the lateral semicircular canal right under here. Okay, smoothly. Now we're turning. This is the mastoid antrum, and then the lateral semicircular canal is right under here. If you turn the head a little bit, you see the you begin to see the short process of the incus. You're correct. So I'm just using a curette and remove the last bit of bone. my position here a little bit awkward. It's not an operating table. Clear needle. Okay, I still need to take away something. Hope, so you can see the septum here. Let me get through the septum and then we'll see. Okay, right. Ah, I know why. Because I've dislocated the incus. So, so the incus, the head of incus should be around here. Okay, so, but I can actually open up the entire attic from going from behind here. Okay, so so because I've dislocated the incus away, so we're not going to be able to find it. But it's okay. So let me assume that we do have the incus right over there. But I show you because I'm already at the attic, but we don't seem to be able to find the incus. Yeah. So I'm still puzzling. So, but it's okay. So I'm opening up the attic. So this show you how you open the attic from the back to the front. So we have opened the attic. So we'll see whether we are able to find the head of the malleus. Neither one. So I can see the dislocated incus right over there. So this is the incus and the malleus right over here. Okay, so here we try to get a guide to find the facial nerve. So I'm opening up the antrum. The lateral canal is behind me, right over there. So I'm reaching the attic. So I can do a little bit more over there and get all the way to the attic. So if I lift the eardrum, get me an elevator. On a combined approach from over here, you'll be able to get manipulation for cholesteatoma, for things with that, okay? So now I'm lifting the drum from right over here. So this was my cartilage graft where I'm pushing a little bit back, okay? Crocodile. So I'm taking my cartilage graft away. Okay. So I will finish now by finding the facial nerve. At the posterior canal wall. Okay, okay. Okay. If I show the suction, I'll see them. Okay, there are many ways of finding the facial nerve. Of course, you would very much like to find the digastric ridge from behind and follow on and connect it to a line, which is right at the incus, where you're looking for the vertical part of the facial nerve, okay? Empirical way of doing it is you can start from getting the air cell system away. You do it carefully and slowly, and you watch for the important white cord structure and try not to destroy it along the way, okay? So when we have to identify it, say for opening up posterior tympanotomy, maximizing it, really, we could use a nerve monitor, of course, but anatomically, you may also identify the chorda tympani in the thin down canal first, okay? Which is the preferred method that I'm using now. But it's of course a more difficult method of identifying the chorda first and then find the facial nerve to follow. For today, let me just find it on thinning down the air cells, get it along. So let me zoom in a little bit. Okay. So I thin down the canal wall along. And look at the cord-like structure. Your side section. So you begin to see the facial nerve gradually. So I'm not telling you that you'll be able to see it now, but I can roughly feel it that it's coming up. So one question is whether you should use the diamond burr for this. I've no objection of using the diamond burr. Okay, so it all depends on how you are trained and how you find and look into the anatomy, which is really necessary to guide you through. So this is a little bit in my way, so I just widen a little bit on the side. So, 幾點鐘呀？ Oh, so okay, we're almost there. Oh. Okay, I don't know why I'm not getting a very good view over the binocular today. Okay, let's finish it. Carry on. Needle. So this is actually the facial nerve right over here. Okay, so we get the facial nerve right over here. Okay, so I'm trying to get the chorda as well. I need a smaller burr. I'm cutting. Not okay, good. So I'm not doing a good job today by just blue lining the nerve. I actually exposed a little bit the nerve, but it's okay. We'll thin down and see whether we can find a chorda. Size 少少啦。It's the orientation. Let me orientate a little bit better. Oh, okay. So we begin to see the chorda tympani right over there. Okay, let's opening up a little bit more.俾個 needle 我啊。Drums over here. Oh, it's okay. So I've got to explain what has happened. Sorry. So let me check what's happened today. Okay, I see. Okay, so so I was mistaking that quarter as the facial nerve. So I actually get through to the ear canal, but it's okay. So let me follow on and find the right. So we've got to see why I'm doing it today. Okay, I see why. Okay, don't worry. 俾翻個4 mm. So it's not a good bone to demonstrate today for you, but it's okay. So I will still carry on. So this is the facial nerve where I'm now showing you. Because the corda was quite lateral. So this time now we're right at the right side. So we get into the ear canal, but doesn't matter. So I'm showing you on a better way now. 俾翻個2.3 喎 2.3. So in the real life, we won't happen like this, but it's okay. So you can see that the facial nerve is now behind the corda. So I was mistaking the corda as the facial nerve just now and get into the ear canal. So now is the proper posterior tympanotomy that we are getting through. So we chase up a little bit of the time right over there. Okay, so it's also good to show you the different anatomy by opening up. So I'm not deliberately doing it, but because we have moved the annulus and the flap away before, so it's sunk into the middle ear. Now we are right at the posterior tympanotomy. This is the corda, this is the facial nerve, and okay, we're ready now. Okay. So I've got to lift away the eardrum. Yes. Let me push the drum a little bit away. There you go, crocodile. 呢度啊，呢度。Section N. So we have a, say, about 2.5 millimeter posterior tympanotomy here. So now we shift to the endoscope through the opening, and then I show you what we can see through it. So this is a posterior tympanotomy, and so we look through the posterior tympanotomy to the middle ear. So this is the pulmonary, right over there. Okay. So I've dislocated the incus, so we just see a little bit of the stapes right over there. So here we are looking at the round window. It is still hiding behind the facial nerve right over there. So we need to remove a little bit more bone over there. Suction. More. Now we can see the round window from right over there. So I widen a little bit more. Sorry. 停咗水就得。So you can see that facial nerve is beautifully shown right over there. And we get an exposure and access to the round window. 我哋冇 cochlear implant 咯，冇。We don't have a cochlear implant to show you how we open up the round window, but maybe on the advanced course we'll do it. Okay. So I still have a few more things to show you, but you can extend the posterior tympanotomy all the way. So where I will show you with the endoscope fairly quickly how you can achieve that. So there's the suction. Right. Okay, suction. Okay, right now. We still have the prosthesis right over there, okay, on top of the stapes. And then okay, I'm marking. So a wide posterior tympanotomy, quarter suction. 而家答嘅。And the lymphatic site I am jugular bulb. Oh, artery. Okay, so I have another 10 minutes. So in the 10 minutes, I'm going to show you the labyrinth from the back. Okay, very quickly back to the microscope.俾隻大嘅 cutting 我先，最大嗰隻係。So I'm widening up here. 落唔成。要翻水，係要翻水。 呢個唔啱。So the sigmoid sinus, I'm blue lining it. So we try to locate the space between the facial nerve. 去返大家。Look for the labyrinth. 呢個3我哋。So from the lateral canal, we are following to find the posterior canal and the posterior fossa dura. 轉唔到呢個頭。得唔得？ So I'm rotating the table a little bit more. I'm about to focus. Okay. So we begin to see the posterior canal right over there. I try to tilt the digital binocular so that we are at a more sort of usual anatomical position, but it's getting difficult. So we're now at the posterior fossa dura, behind the posterior semicircular canal. Let me do it a little bit wider. Okay. 41啦，咁我交俾位置。So I probably won't carry on further, but so show you some of the anatomy, basic anatomy on the cortical, the facial nerve, the labyrinth. I'm outlining it, lateral, posterior canal. So we're beginning to get to the posterior cranial fossa, the sigmoid sinus. We have not put any dye onto the sinus, but if you push through, you can see that there's a tough wall right over there. The facial nerve, I've opened up the ear canal, and then we show the chorda right over there and the posterior tympanotomy. So I will hand over to Weiji for the next section. Okay. Oh, section over there. Okay, so any questions? We answer it, or you have some questions? Okay.
Oh, you got this slide
question.
Oh.
Okay. So during, we have some question. During myoplasty, what's the how to properly reflection the tympanic membrane if the perforation is just near the malleus? Is there any tips not to injure the malleus? Reflectioning edges near the. So I think your question has two different aspects on it. One is what's the purpose of reflectioning the tympanic membrane in a myoplasty? The main purpose is that you're worrying about leaving behind squamous epithelium at the back of the graft, especially if you are doing what we call an onlay technique. So, so you're leaving behind squamous epithelium. So is it really necessary in all the case to refashion completely 360 degree? I don't think it's really necessary. So if you are very sure that you're not leaving behind squamous epithelium, you might not need to refashion completely. The other reason that you want to refashion is you want to find the correct area where you need to place the graft underlay, especially when you have a very irregular perforation. Some of the adhesions are adhering to the edges of the perforation. You need to fashion it so that you get very clear about the edges for placement of the graft. And so when it is near the malleus, we won't hesitate actually to touch the malleus. But if your movement is soft, you won't damage the malleus. Excessive movement, of course, are not very good. You might cause acoustic trauma or actually true trauma by damaging the ossicles. But modest movement along the malleus should be very safe. Okay. So how we decide to do cortical master and when to do modified radical mastectomy. So I think we're talking about different terminology here. So cortical mastectomy is removing the mastoid air cell system. basically, we just outlined modified radical mastectomy is the technique to treat cholesteatoma. So where we actually move away from historically a radical mastectomy. A radical mastectomy means you remove the canal wall, you remove the most of the air cell system, visible air system, then you remove the cholesteatoma, and you don't reconstruct it. Okay, so a modified radical mastectomy means you modify from leaving behind any of those things that you're not remove, or you reconstruct the cavity partially afterwards. We don't talk about flaps for mast cell obliterations today, so maybe I skip that sections. I'll leave that for you to find out your answers. There are plenty of different flaps you can use. So the buttress and the bridge. So I think here buttress you mean just a rim of bone. Um, uh, Basically, it's just an English term about rim of bone. In that we are pointing out many a times to the rim of bone that we're leaving behind, especially for patients where we're doing a combined approach tympanoplasty. So the buttress of bone, the dichotomy that will move forward anterior will leave behind the bridge of the ear canal. So it is easier that the buttress is right over there for you to put cartilage or caudal bone. Okay. So how to stop bleeding from the sigmoid sinus, and how we test for sigmoid sinus thrombosis. So if you see the sigmoid sinus, you can put a needle in, but you will regret, okay, because it will bleed a lot, even with a small hole right over there. So if you have a bleeding from a sigmoid sinus, it's very difficult to stop. If you have just a bone bridge, as you suggested, you can put some bone wax on. On the contrary, most of the time, we do need to expose the sigmoid sinus by exposing it. But if it is just during a mastoid surgery, you expose it accidentally. It depends on how big the hole is, how much bleeding is. You use whatever you have to actually stop the bleeding first, okay? Keep the hole in. You don't allow air to get into the sigmoid sinus. So this is very important. And Surgicel is a good idea. We don't suture the sigmoid sinus because it's very difficult. We can tie the sigmoid sinus, but it's also very difficult. So there are many artificial materials we can use now. Okay, so we normally will use some form of artificial coverage materials to cover the defect, which can stop bleeding. Okay, there are many different choices. I will send you the link later on about these different materials we can use. So CSF leak dural tear, how to deal with it. So it also depends on the size of the leak. Okay, a tiny leak, you could cover it with a small piece of muscle. You can use tissue. A big leak, you might need to suture it, and from widening up a little bit the exposure and suture it. So the leak, it all depends on whether you can control it right at the time. So it has to be controlled right at the time. So you don't leave a leak right over there. So facial nerve decompression, we're not talking about facial nerve decompression for today, but a temporal bone fracture, why we need, oh, sorry, I better answer the other one first. Why we need to find the antrum during mastoidectomy. So the purpose of doing a mastoidectomy really is to, say, one, clear the disease. It's an access to further procedure. or as part of a procedure where we need to access through the mastoid. So the mastoid antrum is actually a large airspace. So the large airspace lead you to the middle ear. If the purpose is to drain the middle ear and to enlarge the so-called pneumatization or aeration of the middle ear, you need to make sure that the antrum is not blocked and finding out the antrum. The mastoid antrum is also an entrance, as I said, to the attic, which I just show you that we can extend all the way and go anteriorly. If the round window is not adequately shown from posterior tympanotomy, will you do retrofacial approach or cochleostomy near to the pulmonary? Okay, so also the purpose of round window exposure is either to do something to the round window. We do have procedure like round window plugging, where we actually will go through transcanal. So go from anterior with the endoscope or the microscope. Usually I do with the endoscope now. And you will always see the round window. At the back, occasionally the facial nerve will be in the way. I won't do retrofacial approach now, okay? So I'm telling you because with the endoscope, what we can achieve is we will be able to use angle endoscope and get a good visualization of the area next to the round window. So the area actually superior to it, which is the sinus tympani, the area of the facial recess, and all the ridges and humps around that line, we will be able to get with the endoscope. Retrofacial approach, we still leave it for the rare case, which we have to extend the axis of the jugular bulb from behind. Okay, so you have sometimes got tumors, glomus tumors that extend from all the way the jugular bulb to the sinus and into the intracranial fossa. So the so-called type D, most extensive type, then we will get along with the retrofacial axis for some of these cases or tumors. So this, I think this is a question which I face a lot of times when residents ask me about the distance of the tympanomeatal flap from the annulus for myringoplasty. If small, subtotal, or total perforation, how you measure, how you do local anesthetic. So these answers are better shown on case by case studies. I don't have a standard flap length myself, okay? So if I do feeling comfortable, if the perforation is fairly anterior and I'm feeling that I don't need to remove the scutum to access the oxicals, I will make a very small flap, okay? I will make a very small anterior flap because it heals a lot better than a flap which is big and there's less trauma to it. Your teacher or surgeon will show you that you have got to leave at least 4 millimeter of skin in the meatus to make a good flap where you won't tear it. I think this is correct as well. So if you're not sure, you measure, you make about 4 millimeter. And how do you measure? So you know your instruments. I use a round knife, standard round knife, which is 2 millimeter to measure inside the tympanic membrane for the perforation size and also for the flap length and for replacement. So how to go doing? So I'm actually if you find the chorda and the facial nerve, you won't go to the ear canal by doing the posterior tympanotomy. So because I was using the exoscope this time, so I can't see I can't differentiate the color of the nerve very clearly. So that's why on this particular specimen, I get to the ear canal. In the normal case, we rarely get to the ear canal. But if you get to the ear canal, if you make a small hole, you can repair it easily. So you won't cause any complications or problems in it. So you can just repair it with soft tissue and there won't be any complications with it. So is it mandatory to do posterior tympanotomy? How long do we bring down the posterior canal wall? So we are not discussing about management of cholesteatoma, arguing towards posterior tympanotomy and canal wall down technique today. So I think I won't answer this one. Labyrinthine fistula, what do you use to cover it? So labyrinthine fistula, first of all, you can identify on the scan. Second, on patients who have symptoms, especially the fistula sign is positive, or when you do cleaning of the cholesteatoma. So if you're aware of it, you need to remove the squamous epithelium on top of it. And if you see the leak is a slow leak, because if you remember the anatomy, this is a perilymph leak. So if you don't use a big suction, suck into the fistula, and you cover that leak with a piece of soft tissue, a muscle, or a fascia tightly, I won't even push it. I will just place it tight, and so that it's not leaking anymore. And I might put a little bit of tissue glue on top so that it's sealing, and or just a few drops of blood before I close it off. If you don't suck it, you don't traumatize it. If you handle it carefully, I've not seen a patient with a dead ear with this technique. No, so okay, don't worry about a fistula. A fistula is common, but overlay, underlay, and onlay techniques. So we're not showing all the techniques today. We're showing the standard underlay technique. I think if you learn the underlay technique for myangoplasty surgery, it's already sufficient for you to manage thousands of patients in your life career. So I'm not saying that you should not learn overlay, onlay techniques. They're useful occasionally. They are much easier to do. One other technique that you would like to pick up is the butterfly graft technique, but basically it's just plucking the hole from outside. So it's part of an onlay technique. Another question is to access the facial recess safely. I will let Wai Ji to show you how to access the facial recess from anterior. Okay, so we are actually finishing most of the question here. So I hope you enjoy the section. So it's not a perfect demonstration. We do have some other perfect demonstration. Break. So excuse me, sorry for that. You'll have a 5 minutes break before coming back. Okay, but for now.
Bye.